Hey everyone, Assalamu alaikum and welcome to another episode of ECREM Talks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I'm your host, Anzal Rehman, and today we're going to be discussing some of the major emergency medicine concepts surrounding neurogenic shock. Now, shock is an understandably feared consequence of any major disease, and though it has been defined in several different ways by various different institutions, essentially it can be described as an acute failure of the circulatory system to deliver adequate oxygen to end organs or tissues. The nuances of shock are often integral to our practice in emergency medicine, as it's often a process that precedes death. Often it's also attributed as akin to the last stop on a train ride to doom, but perhaps it is a little bit more morbid than it needs to be. Nevertheless, in that way, it's a state that we actively avoid and aggressively counter when it rears its head in the emergency department. Since shock is not in of itself a disease, there are several ways to reach that shock station, so to speak. That is to say, there are different kinds of shock that can produce circulatory inefficiency. Most of the references you'll read on or find on the web divide these into four different categories. Now, there's hypovolemic shock, and this is often the one we encounter. The one that we really fear, especially in trauma patients, is hemorrhagic shock specifically. There is obstructive shock, which is, a little less common, but of course it's always in the back of our heads. These are things like PE, cardiac tamponade, or pneumothorax. And the way I like to think of obstructive shock essentially is your heart doesn't really have a lot of room to move around in, or has some kind of an obstruction which is causing pressure on its pump activity. That, of course, vis-a-vis leads into circulatory inefficiency, like we said. There is the third kind of shock, which is cardiogenic shock, which is a little bit more intrinsic in nature. Things like MI or myocarditis, for example, can disable the heart's pump in a way, and that inability to produce efficient cardiac output would then lead to the same inefficiency again, aka shock. And the fourth kind of shock is distributive shock. Now, distributive shock has been a little confusing to me for quite some time because there's a couple of different things on here, but bear with me. We'll be talking about one specific one today. However, for the most part, the famous one here is septic shock. Other things here are anaphylaxis, and the one that we're highlighting today is neurogenic shock. But essentially, distributive shock is more peripheral in nature. And we'll be talking a little bit about how that vasogenic component comes into play. So today, as we mentioned before, we are going to be looking at a particular type of distributive shock, which is often overlooked due to how rare it presents within the shock patient in the ED. But it's important to keep in the back of your head, and very, very important not to miss in your patients. So joining me today to discuss neurogenic shock is Dr. Tasnim Ahmed. Tasnim is a second year going on to third year by the time this podcast probably hits out, and is our next chief resident in Zayed Military Hospital in Abu Dhabi. She's one of the newest board members and serves as a senior technical editor for the Emirates Collaboration of Residents in Emergency Medicine, which is ECREM. Also, she's a technical editor for the Emirates Society of Emergency Medicine, or ECREM, monthly newsletter. She has a special interest in medical education and innovation, and loves to work on a bunch of different creative teaching techniques, and she enjoys incorporating digital art and technology into educational activities. And if you haven't come across one of those yet, I highly recommend you check her out. She's an up-and-coming star. We're very happy to have her on board with us in ECREM, and today with us to talk about neurogenic shock. Welcome, Tasnim.
Thank you, Anzal, for the introduction and for having me on ECREM Talks. And I must say, this topic is very crucial because, as you said, I remember as a first junior discussing neurogenic versus spinal shock always brought me and my batchmates into confusion. So hopefully today's episode will clear out all the confusion about neurogenic shock.
Let's hope so. So, let's start with the basics, shall we? Tasnim, what exactly is neurogenic shock?
As you mentioned, Anzal, neurogenic shock is a type of distributive shock, but one that occurs in patients with spinal cord injuries. Now, as we know, when we injure a segment of the spinal cord, we risk potential loss of the function below that level. If the level of the injury causes dysfunction to the sympathetic innervation, you can lose the sympathetic stimuli to the heart and vasomotor functions, leaving pure parasympathetic vagus nerve action unchecked, resulting typically in hypotension, peripheral vasodilation, and bradycardia.
I am extremely glad that I left that anatomy and physiology for you to explain because I am already struggling to keep up, but I'm going to try to summarize what you just said. Sort of simply put, what you're saying is if a spinal cord injury knocks my sympathetic innervation out, I'm in trouble. It's a bad thing, right? So what level of injury are we really talking about here when it comes to neurogenic shock? I mean, where would injury in the spinal cord risk the technical neurogenic shock?
Well, that's where it gets interesting. Let's start with the basics. So what we're most concerned with is the heart. Therefore, the sympathetic innervation to the heart, if it's knocked out, is what's going to put us into that deadly spiral of neurogenic shock. With that in mind, let's look to the area of the spinal cord that provides the sympathetic innervation. The preganglionic sympathetic neurons are located in the anteromediolateral column of the spinal cord, in between T1, which is the first thoracic, and the second lumbar, which is the L2 vertebrae. Getting more specific, the heart receives sympathetic innervation from T1 to T5. So technically, any lesion above T6 can produce neurogenic shock due to the potential downward disruption of these spinal cord segments controlling the heart.
I sense a big but coming.
There is a big but. While we have conventionally believed for lesions above T6 to be at risk for development of neurogenic shock, several studies have shown that this is not always the case. One paper by Taylor and his colleagues in 2016 looked at approximately 3,000 trauma patients over 3 years and found that in the 15 patients that had neurogenic shock, lesions below T6 were uncommon, but not absent, with 4 cases of neurogenic shock having injury below T6, the lowest of which had an injury at L1. This suggests that even the lumbar spinal cord injuries, neurogenic shock can still manifest. One possible explanation of this is that innervation of vessels is all the way from T1 to L2, and so loss of innervation only to vessels may also result in hypotension.
Okay, brilliant. I think that about packages our knowledge of etiology for neurogenic shock rather well. Before we move on to clinical features and identification of neurogenic shock in the ED, I wanted to talk a little bit about the distinction between spinal shock and neurogenic shock, because to be honest, this always gets me confused. And frankly, I had to look this up just before we recorded one last time because it's hard to get through in my head. Luckily, I'm not the only one trying to figure this out, which, what makes these two things dissimilar. And it turns out that the reason for the frequent confusion between the two is the misconception of the term shock used for spinal shock. Spinal shock is not a form of circulatory failure, or in fact, a subgroup of shock at all. Rather, it's the reduction or complete loss of sensory and motor function below the level of a spinal cord lesion or injury. So essentially, it's just loss of function. It can be traumatic, it can be ischemic, meaning the effect essentially is physiologic in nature. And it manifests as hypotension, sometimes flaccid paralysis, areflexia or dysregulated reflexes, anesthesia, or loss of bladder or bowel control. These symptoms could last several days up to months before they reverse or function returns, which is understandable since basically it's just a loss of neurons that need to regenerate. Conversely, neurogenic shock is vasogenic in nature. It's concerned only with the circulatory collapse that's brought on by that parasympathetic stimulation we talked about. As such, neurogenic shock is more pressing. I mean, that's an understatement, of course. It's a lot more concerning in nature. And it has an understandably different approach to management. This is where the dissection becomes crucial. First, however, let's talk a little bit about how we identify a patient in neurogenic shock. And again, like I said before, this is the one we have to worry about. So how are we going to figure out a person who comes in to the emergency department has this particular kind of pathology? Tasnim.
Right, Anzal. So this is a topic so many MCQs like. And admittedly, this is what you keep in mind on a shift in the emergency department. How does a patient with a neurogenic shock look like? And is it easy to identify when it's present? First off, it's important to keep the differential in mind when a trauma patient comes in with a mechanism of injury suggesting an effect to the spinal cord. Most cases of neurogenic shock are associated with blunt injury to the cervical spine, so a high degree of suspicion should surround patients with cervical injuries. This, of course, is coupled with a neurologic deficit, loss of consciousness, and other factors such as spinous process tenderness or a distracting injury to ascertain whether integrity of the cervical vertebrae should be considered compromised and or warrants further investigation for the spinal cord injury. Along with the traumatic cord injury, what classifies a patient as a neurogenic shock is the manifestation of hypotension, flushed skin, and the classic bradyarrhythmias. Now, essentially, we are looking at autonomic dysfunction in the setting of spinal cord injury with or without a neurogenic deficit. Now, what's extremely important to do before you hang your hat on this diagnosis, remember two things. First, the number one cause for hypotension in trauma patients is still hemorrhage. So hypotension in the setting of trauma, even the setting of spinal cord injury and whatnot, warrants further exclusion of hemorrhage first. Second, remember that patients in neurogenic shock often present with a mixed picture. You're rarely going to encounter a patient who underwent a trauma significant enough to cause a lesion in the spinal cord and nowhere else. Often, you have other areas of bleed and hemorrhage to address alongside the suspected spinal injury. So the manifestation of shock comes from all sides rather than one purely neurogenic.
I couldn't have said it better myself. Knowing the fact that a mixed picture is often how this presents also explains one of the slightly controversial aspects of neurogenic shock. And of course, I'm talking about the association with bradycardia. We have traditionally been taught to believe that hypotension plus bradycardia equals neurogenic shock. However, while bradycardia is possible and definitely explainable, like we said, it is by no means the only rhythm associated with neurogenic shock. Despite the parasympathetic stimulation, it is entirely plausible for all neurogenic shock to have normal or even tachycardic rhythms. However, having the bradycardia associated with it, or having bradycardia in your patient with signs of shock and trauma, it does sort of allow you to make the diagnosis a little bit easier, since hypotension does not usually associate itself with bradycardia and trauma. It's kind of counterintuitive to the physiological response. So it helps you to hang your hat on it, but don't expect that it always presents that way.
Okay, so assuming you have identified shock with appropriate radiographic imaging and clinical examination pointing to neurologic etiology, with or without acute spinal cord lesion, your next step is to manage this unique form of shock. We mentioned earlier that there is a loss of vasomotor tone and peripheral vasodilation, making this a distributive form of circulatory failure. So management here prioritize hemodynamic stabilization initially through intravenous crystalloid fluids boluses. This to try to replace the relative volume lost due to the vasodilation. However, this is usually quickly followed by vasopressors, especially when the fluids alone do not achieve hemodynamic stability for your patient.
Now, several different vasopressors may be useful here. What's important to remember is that your goal is to try and not only stimulate the bradycardic heart, but also increase your vasomotor tone to improve the mean arterial pressure. Norepinephrine is an excellent first choice in this case, as it acts both on alpha receptors, which would target your vasomotor tone, as mentioned earlier, as well as beta activity, which is particularly useful if bradycardia is present. Refractory hypotension usually is dealt with epinephrine. However, there have been several reports and traditional thinking which sort of uses phenylephrine in neurogenic shock, since essentially what it does is it works purely on alpha 1 receptors, ramping up that vasomotor tone and causing peripheral vasoconstriction to counter the damage that's been done by the parasympathetics. However, you have to be a little careful with phenylephrine because while it's pretty useful for that peripheral vasoconstriction, it may cause reflex bradycardia, which can worsen things for a heart that's already bradycardic under fire from that parasympathetic stimulation.
Right, Anzal. And also, don't forget to immobilize that spine. C-collars for those cervical spine injuries go a long way to prevent further harm or even transections in cases of neurogenic shock. The cases may eventually need to be managed by neurosurgery. In neurosurgery, where they may undergo decompression to definitively reverse the insult to the cord, which subsequently leads to a return of adequate sympathetic signals and resumption of normal autonomic function.
All right. As we wrap up our episode on neurogenic shock, Dr. Tasnim will cover the core concept summary for this episode.
Okay, let's recap. So, as we know, neurogenic shock is a form of distributive shock that leads to autonomic dysregulation, specifically the reduction or loss of sympathetic innervation to the heart and peripheral vasculature. This is classically occurs in traumatic spinal cord lesions above T6, usually in the cervical region. However, remember that you may find neurogenic shock presenting even in the cases of injury as low as L1. Also, spinal shock is not the same as neurogenic shock, since there is a loss of the function below the spinal cord and it's not a form of circulatory failure as with neurogenic shock. Also remember, a classic case of neurogenic shock is a trauma patient who comes in with a suspected cord injury and flushed skin, hypotension, and bradycardia. Remember to consider hemorrhage as first differential to rule out for hypotension and trauma, always, and that bradycardia might not always present in neurogenic shock. Also, prioritize hemodynamic stabilization with fluids and vasopressors as needed to reverse the effect of uncoupled or unopposed vagal tone on heart and peripheral vasculature. In this regard, remember that norepinephrine is a great choice as it has an alpha and beta activity. Finally, immobilize the spine and consult neurosurgery as needed for the definitive management of your patient. And this ends our episode.
That concludes our episode on neurogenic shock and our brief overview of its core concepts. I have to say it was an absolute pleasure going through this topic with you, Dr. Tasnim, and we are very happy to have you on board with us at ECREM Talks.
Thank you so much, Anzal. Same here. It's always a pleasure being part of ECREM project. Looking forward to further contributions in the future.
I'm sure we'd be lucky to have you. Thank you again for joining us on ECREM Talks. We hope to catch you for our next episode very soon. Don't forget to check out all ECREM content on ecrem.org and visit our social media accounts through the links in the description below. Until next time, this is ECREM Talks signing off.